Sure. Good. Um, Good afternoon. I think out of the 4 thoracic surgeons, 3 are currently in Vavuniya with the senior registrar. So you can understand the commitment that they have regarding empowering the peripheral units and managing properly the patients. So hopefully, I think you will make use of these opportunities to have a discussion with them as well as our colleagues during the lunchtime. Yeah. So we will be talking about pleural effusion in CKD. And in the morning, as I told you, it is sometimes a dilemma about diagnosis. But basically, it will depend on how the management will be depending on one thing, whether this pleural effusion is clinically significant. The second thing is what is the underlying etiology of this pleural effusion. And the third thing is whether we need to do something about it. So those are the 3 questions that probably might go through our minds when we look at a pleural effusion in any patient, not specifically pleural effusion in CKD. So, but when we look at what the definition for CKD is, just an update. This is from the 2024 April guideline. Now, it is basically CKD is defined and any abnormality of structure or function, they're lasting for about 3 or more months. And we usually have 2 categories of damage that we consider. One is the glomerular filtration rate, another one is the albuminuria. And depending on that, we can categorize according to this chart. The red is CKD high risk, and the green is when the patient doesn't have any other risk factor, that the patient doesn't have CKD. So there is a classification difference that is coming into the picture now, which considers albuminuria, the cause of the renal failure, as well as the glomerular filtration rate. And depending on that, they classify the CKD into various stages. This classification will be important when we discuss CKD and TBE pleural effusion. Now, a word about how the lung and the kidneys behave when you have CKD. So when you have chronic kidney disease, 3 ways the lung will interact with the kidney and it will cause problems to the lung. One important thing is when you have chronic renal failure, there will be an abnormality of fluid load and fluid load balances, which sometimes patients might go into fluid overloads. And the second important way is the acid-base balance, and the patients can go into acidosis, which might affect the respiratory system in certain ways, and sometimes the respiratory system helps to compensate in the acute stage. And the third important thing is chronically, when you have chronic kidney disease, there will be accumulation of various substances that are there in the blood, which can cause increasing of vascular permeabilities, as well as in the long term, it can cause increased resistance of vessels, which can affect the lung. So there are 3 main ways that the chronic kidney disease can affect the lung, and out of which basically the fluid overload phenomena as well as the permeability phenomena will cause problems with the pleural effusion. Right, when we look at pleural effusions, we can define it as transudative and exudative. I think this definition is very important when we try to manage patients with pleural effusion. So transudative pleural effusion is basically an abnormality of the hydrostatic pressure or the oncotic pressure, differences between the interactions between the oncotic pressures and the hydrostatic pressures of the systemic circulation. And in most of the instances, that is the cause. And you can see that many of the causes are systemic causes, not directly related to the kidney per se, or not related directly to the lung. And hence, if the patient doesn't have any significant issues, we can actually manage the systemic cause of the disease rather than doing anything locally. The other important thing is when we look at the exudative causes, especially this article is from India, and because I took this article from India because it's relevant to the Sri Lankan context rather than in UK and USA. When you analyze the exudative effusions, majority of the diagnoses are pleural tuberculosis. So that is an important thing that we have to think about in managing patients with pleural effusions, because if you miss pleural tuberculosis, there will be huge consequences to the patient. And about the lights criteria, I think majority of you will know about the Lights criteria. It is very important to understand what Lights criteria is, and it will depend on the serum protein as well as the pleural fluid protein ratios. Basically, what we are looking at is whether it is due to the increased permeability due to the endothelial damage, or increased permeability due to the inflammation of the endothelium, where you will have increased protein levels in the pleural fluid, or sometimes whether there is an active infection or chronic inflammation that is there in the pleural inflammation fluid, which will cause increased protein, or whether it is a simple leak with an intact permeability, intact endothelium, where oncotic pressures as well as the hydrostatic pressures are playing a role. So depending on that, we decide whether it's a exudate or the transudate. I think protein levels are the ones that we can usually do. So whenever we do a pleural effusion fluid, a full report, it is very important at the same time to send the serum protein level and serum albumin as well in certain instances, because sometimes there might be discrepancies between albumin and proteins, even though sometimes I use albumin to albumin ratio as well. The guideline says about, total protein to total protein ratio can be used. The other one is the LDH level. LDH level will give you whether there is a significant metabolic activity that is going in the pleura. So if it is more than 0.6, it might push you towards an exudate rather than a transudate. So this categorization of a pleural fluid is one of the bases which we will decide how we manage the patient with pleural fluid, even pleural effusions, even in patients with chronic renal failure. So coming back to this, again to highlight, transudative effusions are usually due to systemic causes. Oncotic pressure reduction due to nephrotic syndrome or chronic liver disease might be one of the causes, or else when you have fluid overloads, cardiac failures, which might increase the hydrostatic pressure gradients, it may cause these effusions, and it are systemic. And the exudative causes are basically inflammatory in nature. Mainly, it is infections, tuberculosis, empyema, and malignancy is the other one important thing. And sometimes it can be associated with the pleural effusion of chronic renal disease, which is called uremic pleural effusion, which is actually a diagnosis of exclusion of other causes. Right. So why are we worried about this transitive exudative? So if it is a transudative, we have to think about tuberculosis and other infections. The reason is that when you look at tuberculosis, we can see that depending on the stage of the chronic renal disease, the risk of getting tuberculosis and other infectious diseases significantly exponentially rise in the stage 4 and 5. And this further escalates when the patient is on dialysis as well, because the dialysis membrane as well as the immune dysfunction that is associated with chronic renal failure due to multiple factors will cause increased susceptibility, not only for infection, but to malignancies as well. And for example, when you have chronic renal disease, chronic CKD3 or more, you are 4 times more susceptible to get tuberculosis. And in a patient, it's about sometimes even 11 times more when you have compared to other general populations. Right. So this is one, I think, slide that is very interesting that is coming into the picture recently. So when you have chronic renal failure, there will be what we call gut dysbiosis. When you have gut dysbiosis, there will be accumulation of protein-bound uremic retention solutes that are there in the blood. And these solutes in the blood can cause atherosclerosis. And at the same time, for us, the important thing is these protein-bound uremic retention solutes can impair antibacterial capacity of the macrophages and increasing the risk of bacterial infections. It can cause significant deterioration of the T cell mediated immunity, and hence you can have a risk of increasing risk of malignancy. Other than that, T cell mediated immunity is a very important aspect of tuberculosis. It can have a deteriorated effect on the TB scenario as well. And because of the patient is having B cell responsiveness, hyperresponsiveness, CKD patients might have poor immunoglobulin mediated response to vaccine as well. So sometimes even if we vaccinate these patients, the response of the immunization will be poor in most of the papers. So this concept is very important. So in CKD, not only the hemodynamic abnormalities, the acid-base balances, as well as the peripheral vascular abnormalities will affect the lung in a detrimental way. The immune dysfunction that is associated with the CKD also will cause a significant problem, and this will further escalate the risk of infection, which we will be going to details later. But one of the most important thing is, now, this is actually a study we did in Ratnapura. When I was in Ratnapura, we analyzed about 140 patients with pleural effusion, and we can see that 8 of them we diagnosed as uremic, even though there is no definite criteria to diagnose uremic pleural effusion. It was a diagnosis of exclusion. But when we look at these patients, there were 37 TB pleural effusions, out of which about 5 were in chronic renal failure patients, and we had empyema 42, out of which 7 were in the chronic renal failure patients. And we had malignancies, out of which about 3 were in the chronic renal failure patients. And obviously, heart failure was common in them as well. So we have a vast array of diagnoses similar to the general population presenting with pleural effusions when we think about the chronic renal failure patients as well. Whatever the cause, they have found that if a patient has pleural effusion in CKD, their prognosis is poor, whatever the diagnosis, underlying diagnosis is. So we can see this Kaplan-Meier curve where patients who doesn't have any pleural effusion survives better than patients who are having pleural effusion due to any cause. So pleural effusion is a bad prognostic marker in patients with CKD. And at the same time, it also depends on the size of the pleural effusion. The larger the effusion that you have, the poorer the prognosis that you have. So it has prognostic implications as well. So I will share with you this patient. So this patient is a 65-year-old female with diabetes, hypertension, and hypothyroidism, common patient, multiple comorbidities, coming with shortness of breath, generalized body swelling, and cough for 3 days. And you can see that the patient is markedly tachypnic, but the pulse rate is 70. And we know that certain uremia, sometimes the patient will not have tachycardia like the normal people. And the blood pressure is in the marginal state. And on examination, there is lower serum Krebs, and saturation is about 88 on the air. So this is to highlight that these patients, even though they have chronic renal failure, common things are common. This patient's history, if a good history is taken, probably cough for 3 days, bilateral Krebs, the patient is tachypnic. Most probably, we are probably dealing with a primary viral infection like influenza. This patient's most likely diagnosis is that. Now, that doesn't mean that we have to neglect this small opacity in the left side. That's a pleural effusion. Shall we neglect the pleural effusion or not? Then it is up to us to do. So whether this pleural effusion will cause respiratory distress to cause a tachypnea of 30, I think it is basically probably unlikely in this patient. But can you know whether it's a pleural effusion, or can you know whether it's a pleural thickening? The best is to do an ultrasound scan of the chest. And this ultrasound scan, you can see that there is a small pleural effusion around this area. And probably that is not the cause of patient's shortness of breath as we thought. But because this patient had a fever, and at the same time, the patient had a high ESR as well, we further went into the investigations. But in this patient, rather than thinking about the pleural effusion, I think there are several important factors that we have to think in these patients first, especially whether the patient's acid-base balance is okay. Patient is tachypnic. The patient is a chronic renal failure patient. The reason might be the patient is going into acute on chronic renal failure with a severe acidosis. That might be one reason that the patient is having severe tachypnea. So a VBG, at least, if possible, an arterial blood gas would be an important investigation in this patient, whatever we do. The second is that these patients are very prone to get myocardial dysfunction. Hence, an ECG is important. We can see the small complexes which might indicate a pericardial effusion, but at the same time, they might develop myocardial dysfunction, myocardial ischemia, and that is an important thing. And that might be the cause of shortness of breath that aggravates the respiratory infection that the patient has. Serum creatinine is obviously 456. And the other one is these patients with chronic renal failure are severely anemic sometimes. So the patient's shortness of breath dyspnea might be due to severe anemia. Hemoglobin of 5 or 6 might be the cause. And we might be barking at the wrong tree and looking at the renal failure if we are not looking at these aspects. CRP is 67, significant in this patient. And that is the reason that we have done the diagnostic aspirate, because we didn't want to miss a parapneumonic effusion in this patient. And in this effusion, we can see that the protein is 14.8, with the total protein is about 56. So this is basically a transudative pleural effusion. cells are not very very significant. So this is most likely we are dealing with a primary viral infection exacerbating this patient's lung condition and associated with probably a hypoalbuminemic or cardiac failure related pleural effusion. So probably we should not do anything about it, but we'll keep an eye on the pleural effusion in this patient. If it is increasing and if the CRP and the ESR is rising, probably we have to think about the development of a parapneumonic effusion, and we have to intervene at that point of time. ADA is 1.8. Second patient, hypertension, diabetics, and on regular hemodialysis, you can see this and you can see that in this patient, low-grade fever for 3 weeks, we can ring the ringing of an alarm is there. MAN2 is 6. In CKD, the cutoff point for MAN2 is 5, but this is considered as a positive MAN2 in CKD patient. Serum protein is a bit high. So in this patient, you can see the diaphragm is here, probably a small pleural effusion here. Considering all these factors, whether to aspirate or not is the problem. Whether we will aspirate or not. So this patient history, and as previously said, the probable history of tuberculosis in this patient, it's better to aspirate this patient and see what the look is in the pleural effusion. So lymphocytic effusion, adenosine amylase is 35.9, even though the cutoff mark is 40, we say, but clinical picture and everything probably would tally with a diagnosis of TB pleural effusion. And whether we need a thoracoscopy for this patient to diagnose TB, I probably don't think. We can, thinking about the clinical picture, we can probably start antituberculous treatment and keep monitoring. But if we do a thoracoscopy in this patient, this is not in this patient, you will see this patient they will have probably small miliary type of nodules in the pleural surface. This is actually another patient that we had. Okay. So CKD and TB coexist together in Sri Lanka because we have high degrees of both diseases in Sri Lanka. And one of the main ways of mitigating this effect is by screening for latent tuberculosis, at least at stage 3 kidney disease. So if a patient comes to us with stage 3 kidney disease, probably before dialysis, it's better to screen these patients for latent tuberculosis and treat these patients for tuberculosis as latent tuberculosis as early as possible, rather than allowing them to go into develop TB in the late stage. Because when you develop tuberculosis in the late state of CKD and on dialysis, the outcomes are really, really poor for patients. Another patient, to do or not to do, 60-year-old male, diabetic ischemic heart disease, shortness of breath, pedal edema and malaise for 3 weeks. And pleural fluid protein is 12. This is obviously an exudate, isn't it? It's an exudate and transudate. Sorry, it's a transudate. Cells are not that markedly there, but the MAN2 is 9, ESR is 104. Whether we will go ahead and do a thoracoscopy of this patient to confirm the diagnosis, are we confident enough to say it is tuberculosis? That is the dilemma that we had. So ESR can be high in many reasons, for many reasons in this patient. But because we had the facilities, we want to take the risk, and the patient couldn't afford a adenosine deaminase as well. So we did actually do thoracoscopy, but the thoracoscopy was completely normal. There was a normal pleura without any nodules or anything like that. So sometimes, to do or not to do, we might have to decide, and for the benefit of the patient, we might have to do. Right? Because sometimes it is very important to diagnose these patients properly. Hemorrhagic pleural effusion is one of the major important things presenting with chronic renal failure disease patients. So it is a feature, it might be a feature of uremic pleural effusion, but it can have other diagnoses as well. So in this patient, whom we had hemorrhagic pleural effusion, not very sure whether we can play, right. We can see multiple nodules that are like this coming, and probably this patient had a malignancy. And in this patient, these nodules, the biopsy proved as tuberculosis. So in a patient with hemorrhagic pleural effusion, in patients even who are having, before we think that it is probably uremic pleural effusion, it is always better to think about the clinical picture of these patients before we decide whether to not to or to intervene, especially in a pleuritic effusion patient. So sometimes we might, when we look at this patient, we can see that there are hidden nodules like this there. So again, this patient presented with a hemorrhagic pleural effusion. Possible diagnosis was uremic pleural effusion, but sometimes they might have underlying cancers as well. So Upul wanted me to finish by 20 minutes, right? So I think I'm within time. So the most important aspect of pleural effusion per se, or even when it is associated with chronic renal disease, is that whether we have to intervene or not. So whether we have to intervene or not will depend basically on the possible underlying etiology that we are thinking about, and the hemodynamic and the respiratory compromise that the patient is having. Even though sometimes we might have to intervene when the patient is having a large pleural effusion with mediastinal shift, we might have to intervene very well knowing that probably this might be a transudative effusion due to cardiac failure or any other cause. But sometimes it is better to leave it as it is rather than intervening in that instance. But even a small pleural effusion in CKD, if we have a high degree of suspicion of tuberculosis, malignancy, parapneumonic effusion, and other sinister causes, it is always better to investigate these patients and come into a conclusive diagnosis, because that will affect the morbidity and the mortality of these patients. Thank you very much.
Thank you, Dr. Niranjan, for the in-depth discussion of the chronic kidney disease associated pulmonary complication and the CKD associated pleural effusion. Now open for this.
And what's your advice to come to from diagnosis before we do
Certainly, Dr. Adil, I think especially, that lady whom we did the thoracoscopy and was completely normal. We had to find other causes of high ESR. There were some restrictions as well. This patient, he couldn't afford the ADA, and there were some other restrictions. And sometimes in these patients, doing a CT will also be a problematic cause. So sometimes the diagnosis might not be apparent, or we might find it difficult to get a diagnosis. Then probably if the physician and the surgeon agrees that the pleural disease might be beneficial even without a diagnosis in this patient because of the symptomatology of the patient, I think we should go ahead and do the pleural disease even without a proper diagnosis in that patient per se, because we don't have any abnormalities in that patient. Because if the patient is symptomatic, I think probably we might have to do it, or else patient will recurrently admit and then go ahead. But at the same time, I think you will agree, doing a pleural disease in these patients with chronic renal failure, which immune suppression, have its own problems as well. And we might kill the patient because of the pleural disease as well. But other than that, I think it is always better to go for a diagnosis in these patients. Because sometimes they live for at least about 5 or 6 years more. And if we can come into conclusions and diagnosis, and then we can actually manage this patient properly, I think it will be a good thing to do.
Comment with regard to latent TB, right, where they refer to us when the patient is awaiting kidney transplant.
Yes. Yes.
So the patient is going to AT, they exclude latent TB.
Yes.
So after AT, they will put on immunosuppressant.
Yes.
By then, if the patient develops TB,
yeah.
How to actually, by
yes.
we have to exclude latent TB because we are supposed to take E, and sometimes we are referred to the variations also to do pleural disease. That is, from anesthetic point of view, only they send us because they are scared to give anesthesia. But we have to keep in our mind that we should exclude latent TB. Yeah. Maybe it's liver transplant, maybe it's very crucial.
I think that is the take-home message I think I would like to convey to this audience, because I know that you are dealing with a lot of chronic renal failure patients. So any patients who comes into the category, CKD 2 or 3, at 3, please refer these patients to diagnose latent tuberculosis. We have 2 methods of diagnosing latent tuberculosis. One is doing a MAN2, and the other one is doing IGRA. So at the moment, we can't do the IGRA in the government sector, and it is rather expensive in the private sector as well. But in these patients with CKD3, with diabetes and any other cause, CKDU even, if at stage 3, if we can document whether this patient is having latent tuberculosis or not, and refer these patients for treatment for latent tuberculosis, probably we can stop a lot of patients developing tuberculosis at the later stage, because especially when these patients are at stage 4 and stage 5, especially the MAN2 will be negative in these patients, because they will not have an adequate amount of T cell response. So there will be negativity. And at the same time, even DIGRA will be negative in these patients, even though they have latent tuberculosis and active tuberculosis as well. So if we catch them at stage 3 disease and refer them appropriately, exclude active tuberculosis, and start possibly following them up for latent tuberculosis and manage the patient as latent tuberculosis. Cutoff mark is 5 in chronic renal failure. And then we can actually prevent a lot of unnecessary TBs from happening. Yes.
The problem when correct patient waiting for CKD and latent TB diagnosis. Whatever during the treatment time, the recipient sometimes change their mind. Most of the time happens in the 6 months time. The recipient will change or something will change. Then the patient has to find the other one.
Yes.
So then most of that happens. So if we can handle it beforehand, then better for the patient.
I think that is a very important thing we have to do in this area, especially I think Sachini wanted to highlight this as well. CKD is common in this region, unfortunately. But if we get these patients early and then managing the kidney part is very, very important as well. There is no issue about it. But think about these factors as well. Sometimes we can prevent unnecessary deaths and unnecessary sufferings. And as Rishi correctly said, they have found the donor with various difficulty, probably paying money even though it is illegal, I don't know. But after that, when we are treating for the latent tuberculosis, the donor doesn't want to donate it. Okay? So then the life will change completely. Otherwise,
the data suggests that the diagnosis of the urine to improve the dialysis rate, so that why we get more number of urine that because they are inadequately being dialyzed. The dialysis rate 75% of the
yes. Yes.
So that is one thing. So by improving the dialysis. Second thing that I am surprised to hear the data that you shared on Indian data that you shared on that exudative process of fluid efficiency. That you mentioned as the leading cause of exudative fluid efficiency rather than maybe the Indian prevalence of tuberculosis is probably 3 to 4 times higher than our country. Our settings, I have to perform several purposes.
Yeah. Yeah, the other one, I think, especially when you think about Jaffna, we have a relatively low prevalence of tuberculosis. Now, we did actually, this is one of my DTCT trainees studies. We analyzed 140 to 150 pleural effusions, not only on CKD patients, but all patients. And out of which, I agree, sometimes the diagnosis of tuberculosis pleural effusion is haphazard, because, you can't really have there are no specific diagnostic criteria for TB pleural effusion. You can go into various criteria, but that might be one reason. So some of the empymas they probably would have categorized as TB pleural effusions in Indian setup. But in the Sri Lankan setup also, we actually were able to diagnose out of the 34 pleural effusions, TB pleural effusions that we diagnosed, about 5 or 6 of them were TB pleural effusions. Empymas, in my cases, were low in chronic renal disease patients. Yeah. Yes. Yes. Yes.
And the second thing is that the availability of alpha gene is extremely helpful.
Yeah.
And we do have patients that who are actually having glucose. Additionally, that we don't use the fluid not validated for gene express.
Yeah.
Now the availability of alpha gene express, now the recommended that we can now it is found to be useful in picking up the.
That is one way forward. Specifically, at least in this age group, in this group of patients who are highly vulnerable for tuberculosis. I complain, even they say that the normal gene expert, the efficacy is about 40% of detecting the gene expert. But now the efficacy has increased, the sensitivity has increased. And I think, as you correctly said, one investigation that should be there in the armamentum of chronic CX, at least in CKD pleural effusion, is gene expert ultra. And especially if we are dealing with TB empyema, empyema like tuberculosis, Also, I think there is a place for TB ultras because sometimes if there's a dilemma of diagnosis coming into the picture.
In-stage renal failure, patients with pleural effusions, they are ill patients, they have multiple comorbidities,
Yeah.
they have platelet dysfunction,
Yeah.
etc. So when we offer medical therapies, what precautions we should take?
Yeah, well, I think it is basically clinical judgment, isn't it? The first theory is that you should not harm a patient. You should do a benefit to the patient. So it's always a risk and the benefit that we have to balance. As I correctly said, medical therapies, we do it under local anesthesia and we don't have the general anesthetic cover. So sometimes it can become a high risk procedure as well. So if we select our patients properly, now for that example, even though the ADA was rather low, clinical picture suggesting tuberculosis, I didn't go ahead with the thoracoscopy because clinical picture and everything tallies with the TB pleural effusion. But in that other patient, even though it appears to be transudative, and the patient was rather fit actually, and there I actually thought of doing it because ISR MANT was 9 in a chronic renal failure. If I miss tuberculosis in this patient, that may have consequences. And if I treat that patient as tuberculosis, not having tuberculosis, also you know how difficult it is to manage the drugs in this patient. So there I made a decision to go ahead with the thoracoscopy. So in a very, very ill patient, even if the probability of tuberculosis pleural effusion is about 20%, I would start ATT rather than going with a medical thoracoscopy. But in a patient who is fit and well, if even the probability of tuberculosis is about 50 to 60, probably I would like to confirm my diagnosis before giving anti-TB therapy because thoracoscopy is now currently freely available for us, fortunately in majority of the centers. So we have to do that actually, hopefully. Yes. Having a adverse diagnosis like even malignancy. Yeah, yes. Now in that patient with what you call this hemorrhagic pleural effusion, the first one actually had only septae, multiple septae because of the hemorrhagic pleural effusion, and we couldn't actually. We took the biopsies. It came as uremic. It was negative, but the patient had a marked hemorrhagic pleural effusion, and when the ultrasound scan was done, there was marked septae. So we couldn't exclude, and the CT scan in these patients, it's a nightmare as well, and sometimes you can't conclude about the diagnosis as well. So, but in the other patient who had hemorrhagic pleural effusion, when we look at the adhesions and beyond the adhesions, there were actually multiple deposits for which diagnosis was coming as adenocarcinoma. So it depends. Sometimes we have to make a call. Yes. Uremic effusions, yes. Because uremic effusions doesn't have a conclusive, like TB pleural effusion, it's difficult to diagnose.
But can you brief us regarding patients with end-stage renal failure, current pleural effusion, case of chemical?
Right. So again, depending on the cause, if this patient is having an ejection fraction of 22%,
it's not due to empire,
yes, right.
It is renal failure per se.
Yeah, if it is renal failure per se, why does this patient is having a recurrent pleural effusion? So most likely, oncotic pressure problems, hypoalbuminemia might be the cause. Where probably we might have to improve the patient's, renal functions and the diabetic control and things like that, and as well as the what you call this the nutritional state. That is one possibility. And the second possibility is these patients probably the cardiac failure is there. Ejection fraction is 25 to 30. They might have uremic cardiomyopathies as well as diabetic cardiomyopathies and ischemic cardiomyopathies. So improving the cardiac component might improve the recurrence rate of pleural effusions. In spite of that, if the patient is having recurrence of pleural effusions and if the patient is having a good quality of life and because of the pleural effusion, the patient's quality of life is significantly deteriorating, probably I think there might be a place for pleurolysis. Yes.
Related to your question, the longer you have the effusion, highly likely that lung may not come and after
Yes. Yes.
Take the question whether you can do pleurolysis. You may do, then only the top part of the lung will come and
Yes.
adhere, but bottom part is the bottom can adhere. Again, related to surgeries, which will be invasive procedures and and they are referred to us. So if you longer you
Keep the
you're
ICT.
asking for
Yes.
so how many patients have you seen? Yesterday came for the ICU patient from Malika, written in 5. PKT getting dialysis 3 times, 30 days, and infection, deportation twice, but still he has going in 5. So by then, the chances of going to PKT no more.
Yes.
Because of the infection.
Yes.
Pretty good.
Yeah, that is the part of the traditional training. That's the one.
Yes.
Because that is most impossible situation when the production is well above 100. You can never
What an other one statement. When you know, like PKD patient, liver failure, or American diffusion, you know, if you put that you can't remove. So you have to plan what you are going to do. So you have to so that you know what you are going to catch it. So you have to decide first, most of the time, medical side we ask us to put that if I can not patient C, then if you want to go for approval, it is there. Otherwise, not put the tip, otherwise you can't remove it at all. Right? So clinically, if you have a judgment that this is not going to end, better to remove the tube. This is irrespective of how much brain.
Especially in 2 organ failures, liver associated hepatic hydrothorax and kidney associated pleural effusions. I think putting an IC tube, we should consider gravely before putting it in. But therapeutic aspiration would be the way forward first. Therapeutic aspiration, I think now we have to do it with the aspiration kits actually, at least from the kits. So if the therapeutic aspiration can be done, I think that will be the best. So if the patient is having recurrent effusion and the aspiration, we can think about the differential diagnosis and other things as well. And it will give us time, a little bit of time to optimize the patient's heart. If the patient is on cardiac failure, it will give us time to optimize the cardiac failure, optimize the patient's oncotic pressures as well as the renal functions if possible. As you said, start dialyzing these patients. So probably the effusion appearance will gradually wean off rather than trying to put IC tube at the onset unless there is a significant indication. But empyema, CKD, probably we might have to diagnose it properly and we have to go according to the guidelines that are there for drainage. Thank you. It was a very interesting discussion and thank you very much for the questions and hope that the audience found it very useful. Thank you.
Sajini, madam.
Before moving on to the final presentation for the day, we have a short activity planned for all the attendees. I'd like to thank Dr. Adavan and Dr. Hanagala for chairing the second part of today's program for us. I now invite Dr. Sachini Senuriratna, Consultant Respiratory Physician and Joint Secretary of the SLCP, to proceed with the quiz.
Well, my data the end, I'll learn the answers to the common name. Visual and course color. Sponsors make a point taken.
Thank you very much. So I'll be quick. This is just to keep you awake till the end. So we were hoping to do this in a more interactive and online platform, but unfortunately we had to pay a monstrous amount to do that. So it will have to be on paper. So please write your name clearly at the top I'll be collecting all the papers at the end. And after Dr. Kulpatana's lecture is over, we will be announcing the winners and we'll be giving some gifts as well. Okay, right. And the questions are super, super easy. So if, I can see a few house officers, if you'll be paying attention to what I've been telling you during the ward rounds, you should be able to ace this. Okay, right. First question. So all these questions are a single best answer. So there's a single best answer, write the single best answer. Okay, first one. Which of the following is true regarding asthma? Mild asthma can be managed with salbutamol PRN. Spirometry is always obstructive. Formoterol budesonide inhaler can be used as a reliever. Theophylline is one of the first-line agents in the treatment of asthma. I'll give you a few seconds to answer. In the interest of time, I'll move on. Second question. Which of the following is true regarding COPD? Always occurs due to smoking. First-line treatment is inhaled bronchodilators. Inhaled steroids have a place in treatment of all patients. Long-term antibiotics should never be given. Which is true? Okay, moving on. Which of the following is true regarding Light's criteria? So we've just been talking about this. All of you should answer this correctly. Pleural fluid to serum albumin less than 0.5 indicates transudate. Pleural fluid LDH more than 2/3 upper limit of normal serum level indicates exudate. Pleural fluid protein to serum protein more than 0.6 indicates transudate. All three criteria should be fulfilled to label as exudate or transudate. Okay, moving on. Which of the following gives rise to exudative pleural effusions? Uremia, nephrotic syndrome, congestive cardiac failure, hepatic hydrothorax. Since it's an easy question, I'll move on to the next one quickly. Which of the following is a definite indication for NIV? Okay, so definite indication. 1, victim of polytrauma with lung contusion. 2, head injury and aspiration pneumonia, GCS3. 3, acute hypercapnic respiratory failure in COPD refractory to medical management. 4, severe community acquired pneumonia. Again, none of these questions are difficult. We are trying to hit home some take-home messages. Okay, regarding tuberculosis, can affect males, rarely affects children. BCG vaccine provides effective immunity. Bone TB requires a longer treatment regime than pulmonary TB. Okay, moving on. Which one of the following is true regarding MTB gene expert? Can only be performed in sputum. The information gained regarding drug resistance is frequently unreliable. Has a sensitivity approaching that of TB culture. Takes around 48 hours to perform. Okay. What is the cutoff CD for lymphocytes to develop opportunistic infections in HIV patients? This is directly based on one of the lectures we heard today. Less than 100, less than 200, less than 300, less than 400. Okay. What is the first line treatment option for pneumocystis cerevisiae pneumonia? Voriconazole, itraconazole, cotrimoxazole, pentamidine. Question number 10. Which of the following is false regarding pleural effusions in CKD? So we've just been talking about it. Right. 1. Recurrent pleural effusions refractory to dialysis is a poor prognosis factor. ADA can be effectively used to rule out TB. Gene expert has poor sensitivity in diagnosing TB in lymphocytic pleural effusions. Uremia can give rise to exudative effusions. Okay, question number 11. 33-year-old patient presented following motor vehicle collision and was admitted to Vavuniya Hospital. On admission, he was having labored breathing with flail segment of right lower chest. There was no other injuries noted. SpO2 70%. Hemothorax seen on chest X-ray. IC tube inserted and drained 150 cc blood stain fluid. No drainage after 2 hours of insertion. Which describes the best way to manage this patient at this time? 1. Observe in HDU, intubate and ventilate, thoracic referral, emergency thoracotomy. Please take the locality into context. The patient is currently in Vavuniya Hospital. Last question. 25-year-old male was caught in a gang fight and had a stab injury to the left precordium. He was rushed to Vavuniya Hospital with following vitals: saturation 66, steady pulse, BP unrecordable, pupils reactive. What is the best management for this patient on admission? Resuscitation, emergency room thoracotomy, thoracic referral, admit to ICU and resuscitate. Okay, can I collect the answer scripts now? And if you want, I can quickly go through the answers with you after I collect the scripts. Please write your mobile number as well. We will try to mark it now itself and give you the price. I will try to mark it during the time Dr. Pulpatran does his lecture. But in case we run out of time, we want to contact you to give you your price. So hand over your scripts now, please. And discuss the answers if they want.
I'd like to invite Dr. Pulpatran, consultant respiratory physician, for a case-based discussion on respiratory failure in pregnancy.
Right, thank you very much. So, respiratory failure patients, breathless patients and patients with respiratory failure are commonly referred to the general medical casualty and also the respiratory when they are available from obstetric wards. And so there are some sensitive issues in these pregnant patients, and they are not like the other patients. She is with the baby as well. Therefore, sometimes it is challenging. And when it is a straightforward case like asthma exacerbation, the diagnosis is straightforward and the treatment is straightforward. But when you have patients in pneumonia, high mortality, it is challenging. There may be non-infective causes challenges. So therefore, this is a complex case of respiratory failure in a pregnant patient. And rather than just I am describing this case, I want to have a discussion with you all, because here there are around 10 respiratory physicians and also 3 thoracic surgeons and around 50 doctors. Right, this patient, this is a 32-year-old pregnant lady. At 26 weeks of pregnancy, she developed non-productive cough. And 2 days later, she developed low-grade fever. And for this cough and low-grade fever, she has taken symptomatic treatment, and also she has taken 3 doses of prednisolone 20 to 30 milligram daily. And day 6 of the illness, so until the day 6, she had mild distressive cough and also isolated fever occasionally. And she developed on day 6 breathlessness and therefore admitted to hospital. And her oxygen saturation was low. So on the day of admission, she was sent to ICU. And then following day, she was referred to respiratory team. Then we assessed the patient. So when we go through the history, she had cough with scanty white sputum. This cough was very distressive. So she coughed without any relief of any symptoms. And also there were isolated small fever spikes in fever chart. and there was non-specific chest pain. And she was breathless and unable to mobilize. Now, other systemic symptoms, there was nothing. So in past history, there was no anything significant, and she had a first trimester miscarriage in the past, and she's allergic to penicillin, and other than that, she was on the usual supplementation in pregnancy. Examination, patient looks unwell and has increased respiratory effort. Respiratory rate was 28 breaths per minute. Oxygen saturation 97% with oxygen 60%. Breath sounds equal on both sides. There were fine crepitations bilaterally in lower zones. She was not pale, there was no ankle edema, there was no unilateral calf swelling. Cardiovascular examination, she had tachycardia, other than that it was normal. Abdomen only private uterus. So at this point, this is a pregnant lady with cough and mild fever, and she is in respiratory failure. What are my differential diagnosis? This could be pneumonia caused by either viruses or viral pneumonia with secondary bacterial infection. Or it can be pulmonary edema due to any cause, previously undetected mitral stenosis, even though we can't hear it clinically, left ventricular failure, or simply fluid overload following acute renal failure. So we requested initial blood test, hemoglobin 10.9, there was mild neutrophil leukocytosis, ESR 34, CRP 59, troponin was negative, electrolytes, there was mild hyponatremia. And this is the chest X-ray. What do you see in this chest X-ray? So you see here there are bilateral basal dominant patchy consolidations. So we thought this is pneumonia initially and started on antibiotic because she is pregnant, now in respiratory failure and dependent on high flow oxygen. We don't want to take a second chance, therefore we hit with high-end antibiotic meropenem 1 gram 8 hourly, and also because IV clarithromycin was not available, we started on oral clarithromycin, and also after taking the SOP, oseltamivir 75 milligram twice daily, and also symptomatic treatment for cough. So day 2 in the ICU, morning ward round. She had stable respiratory symptoms compared to the previous day. The lung signs also stable. Patient was clinically same as the previous day. So therefore, the time was not adequate to respond to either antibiotic or antiviral agent. Therefore, we continued the same treatment. And on the same day, at night, called to see the patient during night round by the general physician. And patient had worsening breathlessness, and the lung signs were increased. There were bilateral fine crepitations in mid and lower zones. So therefore, we again went ahead with another chest X-ray. Right, before that, if you have such patient with pneumonia or any other patient, like patient admitted with COPD exacerbations, suddenly deteriorated with respiratory failure, what are the things you want to consider? Is it simply COPD patients, a sudden worsening of symptoms, simply COPD exacerbations, or else what are the things you want to consider? So this type of pneumonia patient, worsening of respiratory symptoms, we should think about the parenchymal changes, whether it has progressed. So all the anatomical structures we should consider one by one. The parenchymal changes, worsening, and then move to the pleura, where the patient has developed pneumothorax. These patients are at high risk. Then the pulmonary artery, pulmonary embolism, it is connecting to the heart, cardiac failure, and also rhythm of the heart if the patient has any arrhythmia. So these are the things we should normally consider. Right. ECG, there was only sinus tachycardia, bedside echocardiogram. There was no any dysfunction, and there was no echocardiographic evidence of pulmonary embolism. So we repeated the chest X-ray. So this is the appearance. You can see the poor quality chest X-ray because of ICU X-ray, portable one, extensive bilateral opacities. Compared to the previous one, it has significantly progressed. So rapidly progressive pulmonary opacities. What are the differential diagnoses we should think at this stage? You can see extensive changes. So we thought these possibilities: progressive viral or bacterial pneumonia despite our treatment, because there are other viruses, not not only the influenza, and also influenza also it might be resistant to oseltamivir, and other bacterial organisms which we are not treating with meropenem and clarithromycin. And also, with the patient is now developing acute respiratory distress syndrome, and then alveolar hemorrhage syndrome. Or else, rarely, it can be interstitial lung disease, like acute exacerbation of underlying interstitial lung disease previously undiagnosed, or the presentation of acute interstitial lung disease like acute HP or acute interstitial pneumonitis. So patient had not had any hemoptysis, but in the absence of hemoptysis, we can't exclude alveolar hemorrhage syndrome, because this bleeding into alveoli sometimes may not cause hemoptysis. But if patient has such a bad bleeding, patient should drop the hemoglobin. Right, keeping in mind, so these differential diagnosis, we review the investigation. By that time, we received the cultures. Sputum culture, there was no any growth. Blood culture, no growth. Sputum may be negative. Gene expert, MTB not detected. Influenza also negative. And repeated urgent CRP, it was 19. Previous, it was around 50. Right. Then thinking about alveolar hemorrhage syndromes, to look for any active sediments in the urine, initial urine microscopy, there was no any proteinuria or red cells. And we thought of this cytomegalovirus infection and also HSV PCR, and the probability was low, and the virologist also did not agree to go ahead with these testing. Procalcitonin problem is it will take some time, and antinuclear antibody also similarly will take time. Right. What shall we do? This patient has now rapidly progressive respiratory failure. The respiratory support is increasing. And if I don't intervene, so we continue with antibiotic, antiviral, not responding. If we don't intervene at this stage, the next day patient might need intubation and ventilation. So, you know, the fate of the patient with respiratory failure need intubation and ventilation, the outcome will be bad. So therefore, at this stage, we should take a decision. Shall I go ahead with HRCT chest? Is it okay? Pregnant lady in 26 weeks of pregnancy, I have done already 2 chest x-rays. Shall I ask this question from Sachini, who is expert in this objective evaluation of respiratory symptoms in pregnancy? Sachini, shall I go ahead with HRCT chest in this lady? Is it safe?
Absolutely.
Thank you very much.
Here you have the.
You can come here.
Right. So first thing is about chest X-ray. It is very, very, very safe. With an abdominal shield, you can take about 1,000 chest X-rays in a single pregnancy. So you should not be afraid of taking chest X-rays. It is equivalent to less than a week of background radiation. So whenever it is clinically indicated, please go ahead and do X-rays irrespective of the POA. That's the first message. Second one, in this lady, now this is a patient with respiratory failure with an unknown diagnosis. So the modern CT scans have minimal radiation to the fetus with proper precautions. So taking the risk of fetal radiation into account, if you do not thoroughly investigate this patient, that is a risk to the mother. Okay, so the main thing as practicing clinicians that you have to do is to give the proper information to the patient to get their consent. So if you weigh the risk and the benefit far outweighs the risk. And absolutely, you have to go for it. Thank you.
Thank you very much, Sachini. So we discussed this matter extensively during our maternal respiratory health symposium. And this is one of the take-home message. Absolutely, chest X-ray is safe in pregnancy, and the benefit outweigh the risk. Always, when you suspect a disease, you can go ahead with chest X-ray. And whenever there's an indication, and also CTs are also safe whenever there's an indication. Right. So therefore, we went ahead to CT scan. This is the appearance of CT scan. So if you want, I can give more images. I want my colleague respiratory physicians also to have a close look at of this CT scans. Right. When you go down, so this is the appearance. Right. Any thought? Anyone want to comment on this CT scan? Adhan, yes, please. Thank you.
There is a bilateral explicitly asked. There is issue of ground glass as well as there's a predominantly very bronchoscopy. There is overlying regular setting. That's a pseudo-placement appearance. Top of that, the density of the last presentation is almost the same as the blood. So this raises the still the differential diagnosis of so still the viral pneumonia, the bacterial secondary are here.
Yes.
They can be planned pulmonary operation, secondary.
Right.
Even pulmonary demand is people cardiomyopathy, myocarditis, myocarditis is possible. But so based on this, so you need additional investigation before I can do based on the data.
Yes.
I would European focus on level. Still for influenza, and then check this like what is the reaction population of mass diabetes system. And also look at the real part of the
Thank you very much, Adhavan. So we also thought the same thing. So this is actually at the middle of the night. So the beauty of working in a DGH, the general physician, myself, and the radiologist, anesthetist, all they are in the ICU by this time with this patient. And right, so we also thought the same things, the alveolar hemorrhage syndromes. The UFR, actually, there was no any active sediment, so it was available by that time, and there was no significant proteinuria also. And the serum creatinine was normal, hemoglobin was stable, blood pressure was stable throughout. And the next investigation, then to look for alveolar hemorrhages, putting the scope in. And so when we consider putting the bronchoscope in for bronchoalveolar lavage, look for alveolar hemorrhages, she's a high risk candidate. So we can't put her at risk of doing this procedure. Patient might need emergency intubation and ventilation if I put the scope in. And therefore, and also the echocardiogram was normal, ECG was normal. So there was no any cardiac failure. The problem with procalcitonin and autoimmune markers, it will take some time. So we can't wait till they are available. It will take days, not hours. And then regarding other viruses, influenza we already covered, and influenza SOP is negative. We discussed with virologist, and he doesn't think about any other viral infection in this patient. So therefore, what we can do in this type of patient? What am I supposed to do? So now all are the relations, patient is in front of us, and relations are on one side, and the whole team is looking after what we are doing, and patient might need, again, intubation and ventilation next day. So what am I supposed to do? Ask the audience, or call a friend, chat GPT, or 50-50. What shall we do? What am I supposed to do? Sorry? Call a friend. Okay, right? Yes. Of course, option, ask the audience. Yes, the audience means our team, whichever the available team. So we all were there. The cardiologist attended, general physician, chest physician, and the anesthetist, and whole team was there. All the specialties, and the radiologist also. So whole audience was there. And yes, we can call a friend. So there are maybe experts on this field and more experienced people. So the people we look at in another angle. So therefore we can call another person and ask. So these days we can send images even through Google Drive to expert. Yes, option. And also, so we don't know everything regarding a patient. So we don't know everything in practice. So we can search and look for what it is. And also, finally, whatever it is, so whatever the people think and whatever our opinion, finally we should take the decision regarding what to do for this patient. Sometimes it is, medicine is not black and white always. So we have to have some clinical confidence and we have to take decisions. In that case, it may be 50-50. So patient might, if we do the correct thing, patient will survive. And if we do the wrong thing, for an infection patient, if I suppress the immunity, patient will die. And inflammatory patient, if I don't suppress the immunity, the patient will end up with respiratory failure, permanent lung damage. So therefore, all of these things would be options. I think so. We did the same thing. And again, so I didn't tell you all one thing in this history. We pick up actually on the day one of the ICU admission. And she had birds at home. There was an exposure to birds at home for the last 6 months until she developed these symptoms. So suspicious of developing hypersensitive pneumonitis. And also on the day of she developed respiratory symptoms, started distressive cough. She had exposed to heavy load of dust. So the working room, the AC machine was broken for a period and it was repaired, and which resulted in release of heavy load of dust, and she stayed in that room for hours and then started coughing. So suggesting some sort of inflammatory response to these dust. And also, so if you can remember your patients, if you have a patient with chronic cough with bronchiectasis, they cough out sputum, so they feel some comfort. So they are comfortable after coughing out of sputum. Your pneumonia patients, when they cough out sputum, they have some sort of relief. These interstitial lung disease patients, they cough and difficult to suppress also. So there won't be any relief after coughing. They just only cough. So the similar cough she had. So I suspected based on that findings, interstitial lung disease. And a CRP was disproportionately low. If this is bacterial pneumonia, so when the patient is progressing, CRP should also rise, not coming down. Now it is 19. And so by this time, available markers are negative. Blood culture, sputum culture, and also the influenza also. And there was no response to antibiotic. And so I discussed the relations of this matter. The educated family, it was easy to discuss. Nowhere in the world it is possible to exclude infection 100% in this type of case. And also HRCT findings, there were bilateral ground glass opacities, bilateral consolidations, and peribronchiovascular consolidations, if you can remember. So suspicious of interstitial lung disease. And also, if we don't intervene in this point, she might need intubation tomorrow. So therefore, we decided to intervene at this stage, and middle of the night, we pulse with methylprednisolone 1 gram. And we don't expect following day any response. And following day, she was same as the previous night. But the second day night, when before starting the second dose of methylprednisolone, she felt some easiness and she was a bit okay. And after pulsing three doses of methylprednisolone, she was quite okay. In day 4, 5 times, we off the oxygen and room air oxygen saturation was 98%. And retrospectively, we received the anti-nuclear antibody report. It was positive nuclear pattern, and ENA was negative. And this was the chest X-ray taken 1 week later. So after pulsing 3 doses of methylprednisolone, we started oral prednisolone 60 milligram, and then we continued it for some time. And steroids were tapered over a few months as she developed blood sugar. So what is the cause of this interstitial lung disease or inflammatory lung disease? Because of the exposure at home and also the workplace could be hypersensitive pneumonitis, sort of acute to subacute, and also organizing pneumonia in post-infectious or idiopathic, or interstitial pneumonitis with autoimmune features or evolving CTD-ILD, or acute interstitial pneumonia. So out of these differential diagnoses for this acute ILD, AIP is highly unlikely. AIP has a very nasty prognosis, worse prognosis. They don't respond like this patient. So therefore, it is not definitely AIP. And also, could be IPAF, that is interstitial pneumonitis. This patient has interstitial pneumonitis and also the ANA is positive. This could be interstitial pneumonitis with autoimmune features. There was no any other CTD features, but this could evolve into CTD ILD later. So other features of CTD. And organizing pneumonia is a bit less likely, but might be post-infectious. Post-infectious one, they respond rapidly, but not the idiopathic one. Right. So in summary, so when you have a patient with respiratory failure with bilateral pulmonary opacity, it's not only a patient with pregnancy, other patients you can think about is infectious etiologies as well as non-infectious etiologies. So pneumonia, viral or bacterial, pulmonary edema, ARDS, acute exacerbation of ILD, and alveolar hemorrhages. So the take-home messages. So one thing already we gave, chest X-rays are safe in pregnancy. So we can go ahead with chest X-ray whenever it is indicated. And don't take steroids haphazardly and blindly. So see, so when you have patients with simple upper respiratory tract infections, you don't need any steroids. Even when you start thinking about for post-infectious cough, this is bronchial asthma. The patient is labeled as patient has bronchial asthma. So there are consequences in the future if you label somebody as bronchial asthma without a confident diagnosis. And history was the key in this patient's diagnosis. There was exposure. And also, so when you deal this type of patient's history and other part of examination might be crucial. For example, in a patient with bilateral pulmonary opacities and respiratory failure, having severe oropharyngeal candidiasis might be HIV with pneumocystis pneumonia. Right, so the key to diagnosis and treatment in this type of case is multidisciplinary team management. Right, thank you very much. So if you have any questions, we will discuss. Rishi, can you come here?
So the pregnancy and asthma, pregnancy-related other respiratory condition. One is asthma, as everyone knows, when the pregnancy progress, weight gain, and all those pushing of the diaphragm, the asthma can get worse. So the treatment should be addressed initially and at least until the delivery done, the asthma treatment to be continued. Other one, I more emphasize the sleep apnea. usually is very much underdiagnosed, underrated. And for the example, I will say that in abroad, the urgent category for the sleep study is one is pregnancy. Only two categories for the urgent sleep study. So because of the hormonal balance and everything, there is water retention and obstruction get worse, and that can cause a worse outcome in the pregnancy. So when a patient, another problem happen is when the patient come to the obs clinic with the features of fatigue and all those laziness, most of the time it's put on the pregnancy. So if the patient is obese and if you're suspicious having sleep apnea, better refer to the respiratory physician and get it addressed and treat. So most of the time, as we are not seeing a lot of patients, usually we underdiagnose that. So that's I just want to emphasize here.
Thank you, Rishi. Because three thoracic surgeons are here, may I ask a question regarding this patient? So this patient actually had respiratory failure. Initially, the cause is actually not, it was not obvious, even though we thought it is prospectively so inflammatory in nature. And somebody can request and somebody can suggest doing a lung biopsy in this type of patient. How safe it is. Previously also we thought about safety of putting the scope into the pleural space in CKD patient. How safe it is to go hit lung biopsy in this type of patient if somebody requests. Can you come sir here? Ah, yes. Yes.
There are now two neonatal centers. I think it's a very good neonatal center. Yes, we might embark with you guys force us to do, but then maybe at least why I know there are centers there are even 20 meters have been divided. UA 2022, but it's very unpaid and all. But best to postpone it the first trimester where the baby can survive. That's one point. And we can do another story here to this problem. Because people can not do the where medicinal match in second right. Then if she has already given what biopsy, they have done the biopsy. The last week we prepared for delivery the NHS and they delivered with the epidural. But there was mild brachial compression and we were prepared to do the surgery in case patients are stuck in the ventilator. Those are the problems you encounter in pregnancy. But we don't want as surgeons to operate when there are physiological changes of pregnancy. You know, the Vilesha will support me. So we could wait at least 1 month to allow time for the physiological changes before we start. The lot of problems bleeding, the change. So it taught my answer. I think you make this the right answer. Whatever the possible tests are then going to what do you think done? That's the time of yeah, you will do that. The right you're making clear about pregnancy and yesterday, generally, I agree with but it is really essential. We have to go because generally after 28 weeks, it's like that. First trimester, there's risk of unfairness. The fetal abnormal, sorry. And the toxic gases. Second trimester, little bit of safe, but third trimester, later second part, second trimester, late part, second trimester, and early third trimester. The chance of delivery. So this period, yes, you really want, you can go for it, but then with how to educate the pregnancy-related complications like hemorrhage, pulmonary edema, and those kind of things can be happening. Or as an alternative, there are other techniques of getting a biopsy if you need, but I don't know if it's practical in our country. One thing is you can do it with myocardium. That is the easiest and feasible option I feel in this sort of cases, rather than going for surgical biopsy if it is not essential.
My question is now, when you are starting night,
Yes, sir.
this distress patient and have a difficulty diagnosis rate why not you ventilate the patient and take some time?
Yes, sir. So this patient, it's a good question. So you saw the appearance in the HRCT. So there are extensive opacities bilaterally. And if it is clear-cut bacterial pneumonia, the answer is yes, but it was not clear-cut bacterial pneumonia. So bacterial pneumonia patients, when they develop such extensive opacities and respiratory failure, so usually at the same time they develop other complications as well in bacterial pneumonia. Might be renal failure, might be septic shock, and the patients are very toxic. And this patient is not toxic, and she appears well, even the patient is in respiratory distress. And so that is one thing we don't think about bacterial pneumonia in this patient. So if it is bacterial pneumonia, yes, we will intubate and ventilate. Other thing, so we have experience with this COVID pneumonia. So you remember, so previously actually, and Dr. Dilesh also explained, in patients with pneumonia, non-invasive ventilation is not a very good choice. And it was a thought actually before the development of COVID pneumonia also. But however, we saw many patients with COVID pneumonia when we intubate and ventilate almost all time. Right. So therefore, so we took actually one step back before intubating and ventilating these COVID pneumonia patients. And similarly, so you see that this CT appearance is similar to such patients. So developing COVID pneumonia and also the hyperimmune response and post-COVID organizing pneumonia, etc. So at that point, myself and the anesthetists and general physicians, we all felt if we intubate this patient, because at that time patient does not need intubation and ventilation. But if it required, the outcome is going to be not so good. So all the features were against the bacterial pneumonia, and there are features for inflammatory. So therefore, we decided to go ahead with anti-inflammatory medication. Yes.
So your question on the biopsy for this patient is only about because of the pregnancy or in a patient who is on active respiratory.
Both are the one, both, because so when we have a patient undiagnosed patient, critically patient, and when we don't have a firm diagnosis, and the treatment also sometimes high-end treatments, and because if we miss the diagnosis, it's detrimental. So, yes. Yeah. Yes.
How safe you mean from hospital ventilation you don't know because the advanced investigation, that one is also up. One thing is we won't be able to if the patient not legal on ventilation, that's the thing. So surgically there's no problem at all for a surgeon. Yeah, for surgeon it's like a biodynamic job. The problem is like when most of the time even that we won't be able to have single lung ventilation with the double tube. If the patient won't be staying with the single lung ventilation, biodynamic lungs are bad. But as such as we can do this, perhaps even if you cannot tell them, we can operate. Yeah, even we can operate. Because there is nothing. Yes. How much additional information that we are going to get from the biopsy?
Yes, that's the thing. Yes. So here, so if, yes, yeah, if I answer this question, if it is okay if I take time. So there are two options at this stage. So one thing, bronchoscopy. So this bronchoscopy also, again, it's not highly invasive, but minimally invasive technique. Anyway, it is invasive. So we have another option. So because I'm telling these things, when we manage such patients, we have a team. So different people have different exposures and different opinion. We should respect to everything, and we should, but at the same time, we are not supposed to harm any patient. So somebody can support, why don't you go ahead with bronchoscopy? Because bronchoscopy, we can do two things. One thing, we can do bronchoalveolar lavage and take samples. And second thing, we can do transbronchial lung biopsy. So again, sort of pathological biopsy. Yes, as Adavan asked, if you take a biopsy, it will show clearly organizing pneumonia. Understand? So it may show fungal organisms, fungal hyphae. So might give a diagnosis clearly if you take the biopsy. Might show the diffuse cellular damage evidence. Yes. So therefore, there is no doubt if you take a biopsy, it will give the diagnosis. But you can't do the harm. So bronchoscopy in this patient. So the bronchoscopy in a critical ill patient, in my understanding, is quite different to bronchoscopy we are doing in the bronchoscopy suite. In the bronchoscopy suite, elective bronchoscopy for patients with suspected malignancies or any other indication is elective bronchoscopy different. So they are stable patients, they are okay. Critical ill patients, when we come to critical ill patients, suppose patient had, so recently also I had one patient organophosphate poisoning, and that patient managed medically and intubated and extubated and again developed respiratory failure, needed intubation and ventilation, and chest X-ray showed lung collapse, so secretions and mucus plug. In such case, there is no doubt patient need bronchoscopy. Understand? And patient might be coming with respiratory failure, suspected pneumonia, intubating and ventilating. But when you review the patient, we suspect actually it is not truly the isolated pneumonia, but there's obstruction proximally with a tumor and causing post-obstructive pneumonia. So to decide on further care, ceiling of care also, we can decide whether to go ahead with bronchoscopy and take a biopsy or just to visualize. So there is no doubt when you suspect a diagnosis specifically or therapeutically, you can go ahead with bronchoscopy. But in addition to that, there are patients with pneumonia. We will take as pulmonary infection, lower respiratory tract infection. Whether to offer bronchoscopy for such patients to either bronchial wash, bronchoalveolar lavage, or transbronchial lung biopsy. So we can think about a few things. One end, so these pneumonia patients, immunocompetent patients. So if you take a 2x2 table, immunocompetent patient, and the second type of patients, the patients described by Manmadan, immunocompromised patient. In 2x2 table, other side, the organisms coming from the community acquired pneumonia, and the coming from hospital acquired organisms. So these varieties are there. So if you take a patient with immunocompromised, and if you take immunocompromised patient, the organisms coming from hospital acquired organism. If you went ahead with bronchoscopy and take sample, the probability of having a positive diagnosis which affect the interventions later is high. Therefore, there is no doubt such patient you can offer bronchoscopy and take sample. Suppose immunocompetent patient and coming from the community acquired pneumonia. So if you routinely put the scope and take samples, nothing you are going to achieve. It's not going to change your diagnosis, not going to change your treatment. No need any bronchoscopy. Understand? So one end, so high risk, so high probability of having a diagnosis, immunocompromised, hospital acquired, and immunocompetent and community acquired. So other two categories, that is immunocompromised coming from the community and immunocompetent coming from the hospital. So these two cases are intermediate, and those cases we should decide case by case without harming the patient. So what is the problem of putting the scope? So when you put the scope in such patients, all the physiologists are affected in this type of patient, and we support with respiratory support. And when you go ahead with bronchoscopy, they develop tachycardia. It affects the blood pressure, it affects the ventilation, it affects the work of breathing, and it affects the pulmonary artery pressure. So all the physiologists are affected and high risk of developing complications. So always you have to think about before putting the scope, whether am I going to achieve anything by putting the scope, and am I not going to do any harm to this patient? So therefore, we thought if we put the scope in this patient, patient might need emergency intubation and ventilation. Therefore, it is not a very good option.
Please suggest to have a isolated MDT for this sort of critical case.
Yes. Yes.
Just come to us if the patient dies, will be called for inquiries.
Yes.
So better to have MDT or isolated MDT.
Yes.
Just one comment about the invasive mechanical I believe that the higher amount of the higher rates of the are being created the fault of the mechanical ventilation. I believe that the patients who are intubations are actually the patients who are dying. The patient, most of the patients who are intubated at a very delayed stage, when they have a very high. We have evidence from the studies when we should intubate patients with the PF patient. What happens is in most occasions, because of the fear of managing then this aerosol generation, these patients that were kept on NIV with 100%. And only when they resaturate while on NIV, they will intubate. But the patients actually that deaths, the patients who are being treated are primarily because of the delay into this night.
Yeah, I think that because during the COVID time, most of the hospitals got the NIV. But from few consultants, not much of the consultants in the doctors, but they have much of the experience in the NIV. They have to start with one of the parameters. They try to go with the NIV for vaccine. Then when unable to go on, then they need to.
The patients on hypo 100% they are not maintaining, and if the rest of it is still very high. They keep on increasing their FIFO on the
And the patient, if the patient got exhausted, they try to increase oxygen and keep on NIV.
So if you say that 100% of the FIFO, they maintain a saturation of 90, below 60.
Okay, right. Thank you about that comment. Actually, may I ask a question? Because this is a discussion, so the idea is to improve the practice. So you also treated COVID pneumonia patients in your unit, and how many patients? So your argument is, so without going for delayed intubations, dying patients to intubate early. Am I correct? All right. So in your practice, so during COVID pandemic, so if you intubate early, how many intubated patients, what percentage of intubations survive in your unit?
Patients who are intubated quite early, it's not everybody. So the IF ratio, so we should continue the HFNC.
What other one trying to say, and what we also trying to establish is there are clear criteria for NIV, and before that clear criteria not to give NIV. So we go on NIV, the exhausted patient and going on failure, and once the patient is going to the failure of intubation, then anyway the effect out.
So they immediately immediately crash. That's what it happens.
Yes, of course, yes.
When to intervene and
The parents can't say that and it's the concept of PCD and it's like the lung protective ventilation. Primary pathology, whichever the lung injury is, the ARDS. So the primary mechanism how we protect the progression of the ARDS is lung protective ventilation. So we cannot provide lung protective ventilation either we can enhanced respiratory side support and HFNC or NIV, or conventional oxygen. For lung protective ventilation, and then proning, and this will not happen when you proning and very patients lung protective ventilation.
Okay, fine. Thank you very much. Okay.
Thank you so much, Apur. So we have come to the end of the program, and we would like to show our appreciation to all the speakers who have come from far away to deliver these lectures. And we have some certificates and tokens of appreciation ready. To present some of them, I would like to invite Senior Consultant Physician of Vavuniya, Dr. Ilan Kumar Babu. Thank you. Dr. Damnika Rasmai. Dr. Fahamid Dagoda.